Good morning, everyone, and welcome to the second lecture of our course Principles of Medical Ethics and Communication Skills. During this lecture, I will try to emphasize on the principles of medical ethics, and we will try also to know how to take a consent and work for the best interest of the patient, then how to respect patient autonomy and confidentiality, and dealing with medical errors and dealing with angry patients. I must disclose first about the conflict of interest. The author do not have any conflict of interest to declare whether financial or non-financial. There were no conflict of interest that may have influenced the conduct or the presentation of this lecture, including but not limited to close relationships with those who might be helped or hurt by the publication, academic interest, or rivalries, and any personal, religious, or political convictions relevant to the topic at hand. The four very important principles of medical ethics are respecting the patient autonomy, and autonomy means self-rule, the ability or the capacity to think, decide, and act freely and independently. It is the patient's right to be involved in any decision about his health. The second thing is the beneficence, that is doing good to promoting of what is the best for the patient. And this is also very important because all doctors, all the medical team is working for the best interest of the patient. The third one is non-maleficence, or do not harm and need to avoid harm, and the treatment must be thought likely to be successful without harming the patient, and potential benefits overweigh the potential risk. This is the meaning of non-maleficence. The justice is fairness in provision of health care, and we do not mean by fairness in provision of health care that providing all the health care for all the patients, uh, whatever the degree of their need for this care, but it is those patients with similar situations should get accessibility to similar health care. I mean that if we have a few ventilators available only for the sick patients, we have to give the priority for young patients, healthy, and those without brain death. And this group of patients should receive, they have the similar situation and they should receive the same health care by putting them on ventilators, and giving them priority over old patients or patients with brain death does not mean that there is no justice, but the justice is to provide similar patients with a similar situations to a similar health care. And we will see this in the future discussion with the case scenarios, and we will know to what extent this is important. We must try to distribute limited resources fairly. Using these resources to aggressively treat a terminally ill patient is potentially depriving others of the treatment. Those four important principles of the medical ethics are of extreme importance because you have to keep them always in mind while you are inside the room, because you will be asked definitely what is the ethical issue of this scenario. So one of those, or maybe all of them, must be present in every scenario. So you have to keep them in your mind and memorize them by heart. So what if the autonomy came against the beneficence? I mean, what if the patient decision, his right to say yes or no, came against his beneficence or getting the best of the treatment? So what you will do at this time? Make sure that the patient is competent. Try to explain the possible consequences of his choice, refusal of treatment, and suggest discussing others, like talking to friends or family members and senior colleagues. But finally, if he insisted that he is not accepting this type of medical service, you have to respect his autonomy, because we have always to respect the autonomy of a competent patient. But what if the autonomy came against the public interest? I mean that patient, his own right to take his own decision came against the public interest and may cause harm to the public. So sometimes the patient's autonomy reflects with the public conflicts with the public interest. In such a case, the latter must be respected, as your rule for the whole society is more superior to respecting the patient autonomy. But you should not have a confrontation of patient at this point. You have to try to discuss him, invite others like his friends and his family and so on, and also talk to your seniors in the hospital. So try not to get into confrontation with the patient, and by the end of the day the patient will uh, be convinced, and he will most likely follow what you have decided him, or what you have asked him to do. But uh, you have to keep this always in mind. Your rule towards the whole society is more superior to respecting the patient autonomy. What if the patient is having an advanced directive or last power autonomy, but the patient is now incompetent and this came against his best interest? So in emergency, follow the concept of best interest, but if no emergency, try to do your level best to apply what is needed to the patient, but involve your seniors and convince the family members, and try to we come to the very important point, which is working for the best interest of the patient. If the patient is competent, so a competent patient may refuse, as I said, any or even life-saving treatment, and this is his right. The patient should be given information about the nature of the procedure or other medical interventions. In case of incompetent patient, the possible approach must be like that. Doctors should work in the best interest of the patients, and relatives and friends may be approached as a source of information to reflect the patient's best interest, but cannot give or withhold the consent. There is no proxy consent for an incompetent adult patient, and the final say here should be for the doctors who are treating the patient. In case of incompetent patient, ask yourself what treatment option would the patient choose if he became competent. Like for example, in Jehovah Witness, who usually refuse any blood transfusion or refuse any form of hemodialysis because the blood will go out in the extracorporeal circulation. So if he's one of the Jehovah Witness, remember that he will prefer to do peritoneal dialysis. So to answer this question, consider the patient previously expressed preferences, his general values and backgrounds, the doctor experience with other patients, last power attorney, advanced directives, and involve hospital legal advisor, and apply to the court by the hospital if there are differences in the opinion or controversy in the therapy. Okay, now we move to the types of consent. We have three types of consent: implied, expressed, and statutory. The valid consent can be achieved only if there is autonomy and understanding, and the patient must be competent and he is fully informed, and consent without pressure. The competent patient is the patient who understands and able to do reasoning, express his wishes, and understand the consequences of his decision. What if there is a pre-formed consent for the drug? Upon admission, the patient signs a general consent, including authorization of treatment. So if the patient told you that I did not sign any consent, or nobody took my consent for doing such a procedure or for taking such a drug, please tell him that maybe you forget, maybe you was sick at that time, but you have to know that upon admission, you or your next of kin sign a general consent, including authorization of treatment. However, physician needs to explain the high-risk medication. Verbal is enough in case of steroids, amiodarone, antidepressants, anti-TB treatment, and lithium, and also in chemotherapy, but a written consent is required in contrast with renal impairment, radiation, thrombolysis with pregnancies, vaccinations, and clinical trials, and also any intervention like endoscopy or renal biopsy. So you have always to remember when you are discussing such cases that you will ask the patient to write a consent or sign a consent. When to examine or test and treat without consent. In case of life-saving procedures, when the patient is unconscious or incompetent to indicate his or her wishes, you can examine, test, and treat the patient without consent. Where a patient is incapable of giving consent as a result of mental illness also. The advanced directive is a written directive by the patient uh, in advance, and it is written by the patient lawyer and signed by the patient, and it must be drafted by the patient or the person with physician guidance and counseling, like the nature and the effect of treatment. It must be written by someone who is more than 18 years and competent. It must be updated every 5 years, witnessed and well informed, and consistent over time, is not changing his mind, clear, specific, medically and ethically applicable. There is no advanced directive, for example, to deprive him from water or from air, no advanced directive for food and water, no advanced directive for treatment that seems to be not effective. So this is the valid advanced directive. The capacity means that the competency. So no capacity, and if there is advanced directive, what you will do if the advanced directive is valid and clear, dated, and the content is specific and updated, and there was a capacity at the time of writing, take approval of the next of kin to achieve partnership and apply the advanced directive instructions. If not valid and not clear, you have to make a committee and work for the best interest of the patient after agreement from the next of kin. But if he insisted to refuse, again make a committee and rediscuss it again with him, or recourse to the court by the hospital authority. And always in the books of the community, if you read about recoursing to the court, you must know this is always done by the hospital authority and not by you. Information to be provided to the patient. We have to give him information about the diagnosis, the prognosis, the uncertainty about the diagnosis, if any, and the need for further investigation, the purpose, the details, and expectations of outcome, and likely the benefits in a balanced view with the possible side effects. The proper information delivered to a competent patient can end up with a valid consent and a healthy doctor-patient relationship. The consents, as we mentioned before, is implied consent, means that the patient, even without talking, he give you his consent and his agreement. Like if you ask the patient to lie down in the bed and ask him to, for example, take off his shirt, this means that he give you a consent to start examining him, and this is called an implied consent. The expressed consent is that the patient will write a consent, or the consent is taken verbally from him. The statutory consent means that this is by law or by the court. Again and again, the history taking in communication station is not allowed except for the social history. So the instructions in station 5, the communication skills, include not to retake or take history except for informations which help you in the discussion with the patient. This is most likely the social history. You will be negatively marked if you do otherwise, and trust the scenario and the examiner. So the social history is by far very important in the communication station, and again it can be only taken during the communication station, and start early by asking about the job, as we told you before, to create a rapport with the patient, and at the same time also to direct your discussion or conversation with the patient. As in case of the driver, and it is asked, you are asked to discuss the epilepsy, or a nurse and HIV, a lung cancer, and asbestos workers. What is battery and what is medical errors? In general, we use the medical errors for both, but you have to know from the start what is battery and what is the medical error. The battery is anything done without consent and without informing the patient and cause harm, even psychological, and the patient do not need to prove it. Even if you examine the patient without taking consent, or you make some harm or some pain for him while you are examining him, so this can be considered as battery. The error is always non-intentional harm, and we always use the term medical error for both battery and error. So don't bother yourself with the term battery and use always the term error. What are the common scenarios in the medical errors? The common scenarios are giving drug to the patient known to have allergy, a high dose causing side effect, or wrong dose causing side effect, or wrong route causing side effect. So if common side effect, the case here is only dealing with angry patient with breaking bad news and not a case of medical error. And how to deal with angry patient? First, we have to create a rapport, listen carefully to the patient and give him time to talk, calm him down, and give him a great deal of sympathy and empathy. Adopt the ICE protocol, ideas, concern, and expectations. Explain and start by saying, we can explain it to you. And if the patient is angry because of a futile case or futile treatment, tell him that, and if he asked you if this treatment is hopeless or not, and tell him that we thought will not help you. Here is some notes about disclosure and confidentiality. First of all, you have to explain to the patient and tell him that he should agree for disclosure of a certain piece of information. But if the patient withholds or cannot give the consent, maybe he is incompetent at the time of the disclosure. Disclosure can only be made in case of law order or in the public interest. Situations where doctors must breach confidentiality are notifiable diseases like TB, meningitis, plaque and food poisoning, drug addiction, termination of pregnancy, births and deaths, IVF with donated gametes, donors and recipients of transplanted organs, prevention of tourism, and police on request. You can give him only the name and address, but not the clinical details. And as you see, they are all important situations for the community and for the public interest. Situations where doctors have the discretion to breach confidentiality. He has the right to breach confidentiality or not. Sharing of information with health team in the best interest of the patient. So if the patient criticized you or commented on that you are dealing with his case or talking with his about his condition with your colleagues, this is your right because you are trying to help him and share the information with your colleagues for the best interest of the patient. A patient who is not medically fit to drive and who continue to drive, this is the right of the doctor to breach the confidentiality or not, depending on to what extent this is dangerous for the community. And a third party is at a significant risk of harm, like partners of HIV positive patients. Situations where confidentiality must not be breached: sexually transmitted diseases, disclosure to prevent minor crime against property or minor harm to individuals, to insurance companies, patient himself has to inform them, and to employers. So never, you don't have to inform the employers, and this is his right to keep this confidential and after death of the patient. Let's take this situation. Mr. E is a 72 years old. He is an end-stage COPD patient admitted 5 weeks ago with pneumonia. His course was complicated by respiratory failure, needing mechanical ventilator. He is unweanable. He is now communicating through written notes, and he expressed his will to take the ventilator off. What will be your action? We will discuss this later on, but try to think about it as a autonomy of the patient, the beneficence, non-beneficence, and finally applying the working for the best interest of the patient. So first, try to evaluate the mental capacity and mood, like request psychiatrist. Ask for the reason of his request. Make sure that he understands the consequences. Ask him if he already discussed this with his family and spouse, and discuss with the seniors if his decision-making capacity is intact. Respect finally his request. So by the end of our talk today, we have to understand the four principles of medical ethics and memorize them by heart because they will be always one of them in any scenario. And what to do when the autonomy conflicts with the beneficence and public interest, the importance of social history taking in communication sessions, the battery and medical errors, and what are the common scenarios, how to deal with angry patient and respecting patient confidentiality and when to breach the confidentiality. Thank you very much and wish you all the best.